30 years ago, I was sitting where you guys are at. So I'm excited to be sitting in front of the future hygienist of America. It's kind of been a long journey for me. I had twin daughters that were born premature, and one of my little girls had a ton of allergies. She had 25 different food allergies, and I had to learn how to read a label. So I was actually appalled at what they can put into our food supply. I mean, petroleum products, all kinds of things. And it really wasn't until 2010 that I started to kind of look at the ingredients that I had been promoting to my patients for 10 plus years. And I don't know if you guys know this or not, but the reason why they are allowed to put toxic chemicals in our oral care products is, do you know why? Do you know what category they fall into? Cosmetics. So because it's a cosmetic, they are allowed to put 𝐂𝐲 407, sodium saccharin, things that are actually, when you look at an SDS sheet, toxic. And your mouth is the most vascular part of your whole body, right? So whatever you're sticking into your mouth is getting into your bloodstream. So as I started looking more into this, I thought, gosh, well, what am I going to recommend to my patients? I just didn't feel comfortable, saying, oh, it's great, go use Listerine, when I'm reading the fact that 𝐂𝐲 407 is an endocrine disruptor and is linked to breast cancer. So, I wasn't comfortable with that. And also alcohol disrupts the oral microbiome. So, we know we have an oral microbiome of 700 different bacteria, both good and bad. So I wanted to be really comfortable with what I could recommend to my patients. I went to the health food store, I looked at every single product that was there, and I was shocked once again, because even at the health food store, there were PEG 40s and PEG 80s and 𝐂𝐲 407 once again. So I thought, you know what, that's it. I'm going to make my own stuff. So I have an all-natural oral care line. It's called Simply Silver Mouthwash. I don't know if you guys know about colloidal silver or not, but it does not disrupt the oral microbiome, which is key. Okay, so it's not like alcohol, which can cause oral cancer or even high blood pressure. Colloidal silver is a natural disinfectant, if you will. So it's going to only kill the bad bugs and not the good. And then I have other ingredients like in toothpaste, nanohydroxyapatite. Again, that is going to be a buzzword for you because our teeth are made out of 97% hydroxyapatite crystals. So when you use nanohydroxyapatite, it's bioidentical to your enamel. So therefore, your body is going to recognize it. It's going to strengthen teeth. And this is science. This is not like, some weird mumbo jumbo. You can actually go and you can look this up. So all of my products are completely natural. And I'm really passionate about teaching people the systemic correlation between our mouth and the rest of our body. I think in hygiene, we tend to be so focused on the teeth, right? Just the mouth is a compartment, but it's not. We know that the bacteria in the mouth can cause heart attacks, strokes, diabetes, right? Because there's no fence from here to here. So whatever bacteria is in the mouth is going to get into your organs. So that's really important that we start teaching our patients, it's not just your teeth, right? I mean, one of my favorite sayings for patients is, oh goodness, what do I say? Not flossing is like wiping your butt cheeks, but not your crap. Okay. And I know it's a shocker, right? But we need to get them to wake up, because our teeth poop every single day. Brushing is only going to get off 60% of that poop. The rest is in the toilet bowl, and that's the space between your tooth and your gum. So getting patients to understand that, they got poop breath. That's why their mouth smells like that in the morning, and the cause of that. And typically in dental hygiene, we're basically, it's periodontal disease, it's biofilm, that's the root cause of everything. But I want you to go deeper than that, okay? Because you will notice that patients are going to come in time and time again. And what are you always doing? What is the treatment for periodontal disease? What is it? SRP, right? Why does insurance allow it every 2 years? Because they know that it never goes away when you treat it this way. It doesn't. And we want our patients to completely get into remission, right? They shouldn't be going into remission disease. I mean, it should not be a death sentence. But honestly, if you take our model and what we're doing today, it is. They will eventually lose their teeth, one at a time. It's a domino effect. So what can we do, right? What can we start doing differently? There are certain screening tools. One of them we use in our office. It's called a Hain test. We know that there are 11 different virulent bacteria. AA, PG, parasite, Entamoeba gingivalis, right? We know that there's 11 bugs in the mouth. But when you're seeing that patient, do you know how many they have? Do they have one? Do they have two? Do they have all 11? In fact, what I did is here on this corner, if you want to start passing that down, there's 2 pieces of information. I brought in an example of a Hygiene test so you can see it. And then also an article on the link of the FN bacteria to colorectal cancer. So you guys can kind of be passing that along as we go. But the Hygiene test, I like it because it has 5 paper points that you actually culture the bacteria inside the deepest pockets. You send it to the lab sends you back a report saying, out of the 11 bacteria, I'm just gonna pull this up really quick. Out of the 11 bacteria, this person, talk about a grunge mouth. Okay, look, we've got nothing here with AA, but that PG, which is, guess what, linked to Alzheimer's, pancreatic cancer. He had FN, that's colorectal cancer. He had the heart ones. I mean, this is a very infected mouth, right? So if your office doesn't do Hygiene tests, there's also oral DNA. I offer an oral DNA test on my website for anyone that wants to see what bacteria that they have. They can order it directly off my website. Also an electron microscope. That would be great if every office had that. We can simply swap the inside of the mouth, put it on a slide, and show everybody. Look at the rods and spirochetes dancing around in your mouth. Isn't that nasty? I mean, it looks like aliens in there. It's disgusting, and people are like, I want that out of my mouth. So an electron microscope is really a fantastic tool. I think it's helpful too when patients can see these levels. It gets them more on board and makes them realize, oh, you know what? It's not just my teeth. Maybe I do have a problem. It's a great diagnostic tool. They can take it to their medical provider. In fact, my own personal doctor does a variation of this test. So I think it is becoming more mainstream, and hopefully with groups like you guys having this education, you can take that to the offices that you work in and say, hey, how come we're not like diagnosing what bacteria these patients have? There are 2 specific bacteria that you can do an SRP on every single month that will never go away, and that is the AA and the PG. It is resistant to scaling root lining. So that's where you have to have some other mechanism in there, whether it be antibiotics. And typically, I have seen that it's usually amoxicillin and metronidazole. Well, metronidazole is what? It's an anti-parasite medication, and it's nasty. I mean, you can feel sick. You know, when you're doing a parasite cleanse, I don't know if any of you guys have ever tried one, you can feel pretty sick, right? So, and it's the same thing with the Metro. Sometimes it's just clindamycin, sometimes it's just amoxicillin, but we want to definitely get to the root cause. I am a certified biological dental hygienist, so I try and kind of take things a little bit the more natural route. Your gut, you have, you know, your immune system, 70% of your immune system is in your gut. So when you take an antibiotic, you wipe out all the good flora, right? And your mouth is a mini immune system. So we really want to find a balance between killing the bad bugs, but not wiping out your entire, your whole gut flora. So here's the standard protocol is antibiotics, but then there's probiotics. Personally, I like the Probiora. It's a chewable tablet. I like it because you're specifically getting the saliva to come in contact with the probiotics instead of taking it into the stomach and having it, you know, a lot of it just get killed off from stomach acid. You're chewing it, and it specifically kills the Streptococcus mutans and some of the other bad bugs that are causing that periodontal disease. So probiotics are great. Science has shown that if someone is dealing with periodontal disease, they are actually lacking CoQ10 in their body. Did you know that? CoQ10 is essential. What CoQ10 does is it helps the body fight off the bacteria that causes periodontal disease. So I would say 50 to 100 milligrams a day is really important, and they need to take that with food. If you have a patient on a statin, ask them, did your cardiologist recommend that you take CoQ10? Because they're supposed to. If you are taking a statin drug, it is robbing it out of your heart. So you need to be supplementing with CoQ10, 50 to 100 milligrams a day. Another supplement that's super, super helpful when you're dealing with an inflammatory disease like periodontal disease is vitamin C. 1,000 milligrams in the morning and 1,000 milligrams at night. Obviously, you can't take all that vitamin C at once. Your body won't be able to absorb that. So that is also really good. And women, did you know that you only have until you hit menopause to be building your bone? I didn't know that. That would have been really nice to know when I was your age, okay? So a little too late for me, but vitamin D3 with K2 is super, super important. Get your women patients, especially on this. Women tend to lose more bone than men. You need the K2 because the K2 helps your body absorb that vitamin D3 much better. Also pomegranate. Pomegranate is a really good way to just help deal with inflammation in the body. When you're seeing somebody with chronic inflammation over and over and over again, ask them to get a CRP test. A CRP test is a simple blood test. It's like $40 and it can save someone's life. Because if that inflammatory marker is up over 1, that can be a serious sign of having a cardiovascular event. Okay, and other issues, I mean, maybe it's even autoimmune, it could be even lupus. So have them get a CRP test. If you're seeing your patient come in and they're constantly bleeding, constantly infected, there is a root cause. So my job is to hopefully get you guys to see that there are underlying root causes that we're just simply not aware of and we're not being taught in dental hygiene school. So I want you to start thinking outside the box. So a CRP test is fantastic and really gives a good baseline. Has anyone ever heard of an MTHFR mutation? No. Do you know that 50% of Americans have this mutation? 50%. This is important because if you're seeing your patient not responding despite the fact that they're flossing like a freaking maniac, they're water picking, they're having their electric toothbrush, they're doing everything that you're telling them to do and they're not getting better. We need to be able to figure out what that underlying cause is, okay? Is it bacterial? Is it parasitic? Is it an MTHFR mutation? It's a simple test that they can buy at Amazon. It's like $110. It's a swab. They send it off and then they get a lab report saying, yes, they either have this mutation or they don't. The reason why it's so important is because it can impair healing. It creates systemic inflammation. It reduces the body's ability to detoxify. If someone has a gallbladder issue, chances are you have an MTHFR mutation, okay? It also affects DNA production, hormone metabolism, neurotransmitter function, brain health, digestion, and cholesterol levels, all from having this mutation. So it's really important that if you do have this mutation, you find out because you're not getting enough folate. And for women that want to have children, this is important because if you don't have enough folate, what happens to the baby, you know? Spinal bifida, exactly. So there's issues that you can get if you are not getting that folate. And you want to take it methylated, a methylated B vitamin. Okay, it's called L-methylfolate or methylcobalamin. Things that you can do when you have an MTHFR mutation to help your body detox, something like a sauna or Epsom salt bath. That's also very, very helpful. So, you know, if you want to just add that to another test in the back of your mind as to something to be thinking about when you're dealing with chronic disease. A third issue that can be an underlying cause is oxalate toxicity. Does anyone know what an oxalate is? Oxalates are found in most of your vegetables. Spinach is a high oxalate. Potatoes. How many people love French fries and mashed potatoes, right? Even rhubarb, beets, pretty much anything that comes from the ground is going to have an oxalate. But what can happen is because that compound, it binds that mineral to the food and it forms these sharp crystals. So how that impacts oral health is inflammation in the periodontal tissues. It can create a pathogenic environment for that saliva, right? And then what's happening is if you're oxalate toxic, you're not getting the calcium and magnesium. So that without calcium and magnesium, are you going to have healthy teeth and healthy gums? No, you need to have healthy amounts of calcium and magnesium in your body, right? And too much oxalates can be kidney stones, but not everybody is going to realize. I've never had a kidney stone, but you know, you have. I've heard they're extremely okay. So then you need to be on low oxalate diets. Now you can't just stop eating oxalates. If you are oxalate toxic, you just have to slowly start reducing the amount of oxalates that you take in. The reason I know about oxalate toxicity is because, are you guys familiar with the Piper Clinic in St. Pete, the T&J?
Yes.
Okay, so world-renowned. People fly in from all over the world to have Dr. Shaw do the TMJ surgery. And as hygienists, we pretty much know regular TMJ surgery is a failure, right? I mean, it just doesn't work. But I had been dealing with this for years and years. And when I was 8 years old, I was riding my bike downhill. I lived in Wisconsin, and I hit a patch of sand, went flying over the handlebars, and landed on my chin. So that stunted my ramus bone, believe it or not, and just years and years of dealing with it, I actually lost 60% of the bone on the right side. So what Dr. Shaw did is he cut my stomach, took fat from my stomach, grafted it up into my joints, and I was basically wired shut for 10 months. So I was so concerned about nutrition. You know, all I could eat was mashed potatoes. And I was having all these green smoothies. And the more green smoothies I had, the worse I felt, the sicker I felt. I was like, what the heck is going on with me? So I started doing research, and I found out, there's a test called an oat test. Maybe I should take that. So I took that test, and when I got my results, I was like, oh my God, no wonder why I feel so bad. I was so far oxalate toxic because I also have an MTHFR mutation. So when you're aware of the things that your body has, it just helps you make better decisions. It helps you identify things in your patients that perhaps you wouldn't realize, right? I wouldn't have known about oxalate toxicity if it hadn't happened to me. So things that you can do if you are oxalate toxic is do probiotics, and calcium citrate and magnesium supplements are really good. And, you know, try and have a lower oxalate diet. And unfortunately, chocolate, I know. I've had to cut back. It's been rough, but I'm definitely feeling much better now that I've kind of changed my diet from that. So the fourth underlying root cause that I want you to really focus on is airway health. Now, when I was in hygiene school, I had no idea how to even evaluate an airway. Are you guys taught that?
Yeah.
Yes. Fantastic. Okay, so airway health is super, super crucial because if they have a dry mouth, xerostomia, what's going to happen? They're going to have cavities. They're going to have gum disease, right? Because they're drying out that oral microbiome. So I don't know if you guys know this or not, but when you have open mouth breathing and they're breathing through their mouth at night, it keeps that patient in a state of sympathetic nervous state, fight or flight, all night long, fight or flight. So that means our body can never get into the parasympathetic rest or digest. So we want to start catching this in little kids, because the little children that are clenching and grinding their teeth at night, guess what? They have an airway issue. We need to be evaluating their airway. There's something wrong. And if we can catch it when they're early, we can get that growth, development to not be vertical growth, where they're going to get the longer face, the recessed chin, but the wider jaw, which will create a healthier airway. And having a bad airway is going to end up on a CPAP machine. Just give it time, right? And what's going to happen? You're going to have high blood pressure. You're going to have, ADD, anxiety, depression, all of this because they're breathing through their mouth at night. Now, I know you've probably seen the whole TikTok and all of that. Oh, just slap some mouth tape on there. It's going to magically change your jawline. Well, it doesn't, because we're already developed. Now, it can in children, but if you notice, what happens is when you put the mouth tape on, if you are a mouth breather, you're going to rip it off in about 5 minutes. Do you know why that is? You are over breathing. You have too much CO2 in your lungs. And when you breathe in through your mouth, your lungs are not designed to filter air. It takes 65 days minimum to filter the air that you breathe into your mouth, as opposed to 15 minutes in your nose. And then you don't have any nitric oxide. What's nitric oxide important for? Just a host of things like dilating blood vessels and increasing your oxygen. It's super important that you have the nitric oxide. Let's see. Yeah. So the whole part of airway evaluation, since you guys said that you are familiar with it, are you familiar with myofunctional therapy? Kind of, a little bit. Okay, so part of myofunctional therapy is really understanding how that airway affects everything. It's dealing with tongue ties, and I didn't even know what a tongue tie was. Now, in hygiene school, we know what 𝐂𝐎𝐍𝐍𝐄𝐓 is, right? It's the tip of the tongue. We can easily identify that. But has anyone heard of a posterior tongue tie? You have? Okay, some of you have, some of you haven't. Well, I hadn't. I mean, I've been doing this for 30 years. I was absolutely shocked that all this time I've been missing it. I was missing clinical signs of airway, of posterior tongue ties in my patients for all these years, and it just made so much sense. So what we're trying to do in myofunctional therapy, it's kind of like physical therapy, but for the mouth, right? We're trying to strengthen and tone through exercises. There's different grades of having a posterior tongue tie. You've got grade 1, which is pretty much normal. Grade 2, which I was, it's kind of a little more trickier to evaluate. And then grade 3 and grade 4. Those are the ones that usually need surgical intervention. So you do want to be working with a doctor that has been to either the Breathe Right Institute or Dr. Baxter's Tongue Tie Academy. Very knowledgeable, because again, dentists, they're not taught this. Dental hygienists, we're not taught myofunctional therapy. It's like a separate certification. I hope someday all of us in dental hygiene will have that same knowledge when it comes to myofunctional therapy, because we have the ability to look at someone's mouth and within 2 minutes determine disease, right? Whether or not that person is healthy. They can be eating clean all they want, they can be exercising all they want, but if they have disease here, are they truly healthy? No. So we really need to be getting this into people's heads. I mean, it's just so important that we identify these things. So some signs in having a posterior tongue tie is that when you have your patient sitting in the chair, you have them try to lift their tongue up to the roof of the mouth. So the spot for the tongue is right behind 8 and 9. Okay, so the tip of the tongue should be up behind there, but not just the tip, the back part of the tongue. Like a light suction, that is home for the tongue, should not be laying on the floor of the mouth. Okay, so if you are scalloping, you ever look in someone's mouth and it's all scalloped? It's because they have a low tongue posture. That's not good. That means their airway's affected. That means they may not have enough tongue space. So that is a clinical sign that person has an issue. You need to look at that. Also, a heart-shaped tongue, having a heart shape there, that is a sign of a posterior tongue tie. And have you ever worked on a patient where it's like, oh my God, they're so tight, like relax your freaking cheeks and your lip, right? You're like trying to get in there when they're like that. That's terrible. They usually have a tongue tie that has not ever been treated. So that is just going to be like, oh, I'm noticing that this person is, so rigid when I try and get in there, and let me look at that tongue. Can you, have them raise their tongue, but then what you need to do is take your finger and you lightly push down on the floor of the mouth. So you're able to see if that tongue is not staying up on the roof, they're tethered there. And what I mean by tethered is, we all have a frenum, but when that is tight like that, that fascia is literally, it's one piece. Did you know that? It's one piece from your mouth all the way to your toes. That fascia can be so tight that what happens is the body naturally compensates by putting your head forward. So you get this forward head posture. Guess what that does? It affects the neck, can cause TMJ, migraines, the clenching, grinding. All of the clenching and grinding is a sign of an airway issue. It is not normal for children to be grinding the heck out of their teeth. It just doesn't go away. It's a sign that their airway is compromised. So you want to work with like an orthotropic orthodontist that's going to be expanding everything as they're growing so that airway can have the opportunity it needs to be where it should be. So all those signs of having a tongue tie is super important. Chronic snoring, sleep apnea, all of that, it's all an airway issue. Yes.
What age would you start recommending that someone get seen? Because my son, he grinds his teeth really bad. It's to the point where like he broke this.
Some orthotropic orthodontists won't work with a child past 8. So you want to get it as soon as possible. In fact, the babies having a lactation specialist, a lot of times hopefully they're aware of a posterior tongue tie. Had I known that, I would have been able to get one of my twin daughters to the breast. She refused to take the breast For 10 weeks I tried because, they were in the NICU and she had nipple confusion. But now I know she had the posterior tongue tie. She had scalloping, all of these issues. And I'm like, gosh, I wish I had known that when she was little. I would have had it addressed. And, we could have saved ourselves a lot of money. But, and two, what's going to happen is orthodontic relapse. You ever see a patient, they've gone through ortho, 5 years later, those teeth, did you ever have braces? Because teeth are soldiers. They're going to go wherever that tongue dictates. So it's so important that we identify these posterior tongue ties, that we make the recommendations, whether or not they need to see a pediatric doctor. In Carrollwood, there's Dr. D. In the Riverview, Apollo Beach area, Dr. Casey Lynn. He and I worked together on a few cases. Casey Lynn is really, really good. He went to the Tongue Tie Academy, and Dr. D did Read Right Institute. They're both excellent. But if you suspect your own children, I would take them to one of those two because they're very, very good. So basically, another thing you can look at is that person lisping. If there's a lisp, there's usually a posterior tongue tie. And ask your patients how they're feeling when they wake up in the morning. Are they feeling rected, or are they dragging a hat? Because if they are, you definitely want to address the fact that they might need a sleep study. A lot of times women, the thinner, more athletic type woman has something called UARS. Have you ever heard of that? It's called upper airway resistance syndrome. It's not going to show up on your typical level 2 sleep study. It's a specific polysomnogram that will detect UARS. So I always ask my patient, how are you sleeping? Do you feel rested in the morning? If not, why? Start asking questions. Talk to them about nutrition. Talk to them about their home care. And by the way, hand them a mirror and show them how to brush and floss, because nobody does it right. You literally have to show them. I'm like, oh, you floss? Oh, yeah, I floss every day. Really? Can you show me what you're doing? And then I hand them the piece of floss and they're like, they don't know what they're doing. So I show them exactly what they need to be doing. So you want to make sure that you're really going over that with your patient. But there are four pillars of myofunctional therapy that we focus on. The first one is the nasal breathing, because like I said before, the mouth is not meant to filter the air. It has no way to humidify anything, no way to detoxify anything. So the whole goal in myofunctional therapy is nasal breathing 100% of the time, okay? And again, you might need to refer to an ENT. Sometimes there's an issue. Maybe it's an adenoid issue. Maybe it's turbinates. Maybe you have a deviated septum, but make that referral to an ENT and have them evaluated, because if there is a physical reason that they can't nasal breathe, that needs to be addressed. It's not going to go away with myofunctional therapy. There's an actual physical reason why that patient cannot nasal breathe. Sometimes it's allergies. Sometimes they're allergic to a cat that they have in the home, right? You can do nasal hygiene, you can use some antihistamines, but you want to find out, why is it that you cannot breathe through your nose? You should be able to breathe through your nose. So that's super important. The other goal in myofunctional therapy is a lip seal. We want a lip seal 100% of the time. You ever see somebody and they're just standing there with their mouth open all the time? Come on, you've got actors that have that gnome face, and that open mouth posture is not good. That's that open mouth breathing, and when that happens, then you get the what? You get the longer face instead of that squarer jaw. George Catlin, he wrote a book called Shut Your Mouth and Save Your Life, I think back in the 1800s, and he observed the American Indians. He was observing them because their children were so much healthier than everyone else. So he went and he started to see, well, what is it they're doing different? And after nursing, the moms would go and shut their baby's lips, physically, close their lips. And then when they were in the pacapooses in the back, if you notice, that baby had to pull its head back so its face would be suffocated. Well, pulling that head back strengthened all of the muscles, and it created that wide jaw, that airway that's so important. And so he wrote a book about this in the 1800s. So that information has really been around a while. What started to change was the American Industrial Revolution, when women went to work. stopped breastfeeding their kids as much, and not breastfeeding, nothing replaces breastfeeding. Yeah, and I get, stuff happens. I mean, I was only able to, I was able to pump, but since one of my girls wouldn't take the breast, I had twins. I pumped, and then I had to give them a bottle. I wish that I could have done something different, but it is what it is. But ideally, you want to breastfeed, because that